much. I apologize, my Portuguese is not very good. But I will try to speak and explain what we have here. We are very excited to be introducing the DigiFix in the Brazilian market, and I want to thank George and Andre for bringing it to you guys. So what I'm going to do now is to show a slide presentation to make an introduction for this device. Okay, give me one moment and I will share my screen. Okay, so I will move on. So basically what we're going to talk about is an external fixator that was designed specifically for the finger. And the reason I came up with this was because there was nothing out there that allowed me to use on the finger, because a couple of the products that had been around were taking off the market, and everything else that still existed was too big. So we came up with this idea that we should specifically design a small external fixator frame to use for the hand and the finger. And this is what we came up with. And the concept is very, very simple, where you have two brackets on the outside and the pins are just K-wires, which you can drive in through the fingers and then attach them onto the brackets. So that's just the basic concept of it. In terms of the components, there's just these brackets and these K-wires, and that provides you the basic construct for everything that you will need. So how do you put on this external fixator? If you look at the anatomy of the finger, all the vital structures are volar to the bone. So if you drive the pin in anywhere in the dorsal arc, it's safe. You might impale some tendons, but because these are smooth K-wires, the impalement of the tendons will not cause irreversible damage. So this is what the external fixator frame looks like, and there's a cutout where you can see the internal mechanism. So there's the proximal portion here, and then there's the distal portion. These holes are spread apart so that you can get the pins in at various points in the bone, and they all lock. They all lock through this internal mechanism. Basically, if you turn this screw, this driver will push up against the pins to hold the pins onto the brackets. Now, on the proximal end, only this most proximal hole will lock in with the set screw. This hole does not lock in at all, so therefore we call that hole the axis pin hole. And I'll show you a little bit more here. So what's the purpose of this diamond? Well, the diamond, as you can see, it can stretch out. So when it stretches out, it spreads apart the distance from here to there. So therefore, it lengthens, basically it lengthens the distance between the holes, and that gives you some distraction. Now, it can go the other way also. You can push them together, and then the holes in between will shorten, and that will give you compression. And there's a special device to do that. And you can see how that opens up the brackets. So here you can see this is the normal state that it comes in. And if you want to lengthen it, you can use a pair of pliers to squeeze down from top to bottom this diamond, and then that separates the hole. And the same token, you can go the other way by squeezing down from top to bottom. I'm sorry, by squeezing from, by opening up from top to bottom, and that will shorten the diamond. Therefore, it gives you compression. This top one gives you, but when you squeeze it down, it gives you about 1 millimeter of distraction. And when you open it up, it gives you about 1 millimeter of compression. You can see how when we line up this line on the axis hole, you can see how when you lengthen it, this line, this hole is more distal or longer, and then this is shorter. So some of the cases that we can use this for. So as you know, a lot of external fixators, you hear about static mode, meaning that it doesn't move at all. And this is used for fractures or fusions. So here you can see how this is a proximal phalanx fracture, is very comminuted, and I decided to put on a static external fixator. What makes it static is just that this segment doesn't move at all. And when you put two pins in on either side of the fracture, then it does not rotate through the pin at all. So here's a couple examples of that. This is a unilateral frame. In a lot of instances, I like to use quadrilateral or bilateral frames because that makes it more stable. So the indication for the static mode are shaft fractures, such as in this case, bone loss, such as in this case. This was due to a saw injury, both these fingers from one saw injury, and arthrodeses. So in cases where you need to fuse the PIP or even the DIP joint, this is very good if you don't want to do an open procedure. So now that's the static mode. We can do also a dynamic mode. Well, what makes it dynamic? If you put it in a dynamic mode, what can occur is that this will rotate, and that's what makes it dynamic. So it just rotates about that joint. So this frame actually will rotate as the joint rotates. It rotates, this whole frame and the finger rotates about this pin, which we call the axis pin. So here's just an example of what that looked like. So what's the indication for the dynamic mode? Well, fracture dislocations, that's what we see quite often, right? This is a dorsal fracture dislocation. Now, similarly, the pilon fractures, where both the dorsal and volar fragments are just completely split apart, and therefore you need distraction. Well, the advantage of the DigiFix is that once it's distracted, it can still move, that joint can still move, so therefore it restores the joint health. And you know, in some rather uncommon cases, this happens to be a recurrent enchondroma, where it was going very close to the joint and it had fractured a couple of times already. So I believe that that's also a good indication for external fixator. So here's just a case which I think a lot of people think about when they talk about external fixators of the finger, is the fracture dislocation. This is a 45-year-old who injured himself playing softball. Well, he showed up to me at 5 weeks out, which makes this injury very, very difficult to treat. So those are his x-rays. I took him to the operating room a week later, and under local anesthesia only, performed this open procedure on this side because it had been 6 weeks. I could not get the joint reduced. I had to open it up due to soft tissue releases, then applied the external fixator. And what you notice is that, you see how these pins are bending the other way? That means that I'm spreading the joint apart, so therefore I'm distracting the joint. And this is what the x-rays look like. He did not have any formal therapy. The external fixator was on for 5 weeks. And this is what his motion is at 4 months out from surgery. He had no pain. Motion is nearly full, but not completely. And his DASH score was 4.5, which was 0 was no disability and 100 is a complete disability, right? So the other feature is, if you remember back to the diagram, there's this hook on the frame. Well, that hook is used to attach rubber bands. And if you can see here, it's used to attach rubber bands. Let me see if you can, right? And the only thing that's additional is this anchoring pin that we put through, which is represented here. And that's just so you can attach one end of the rubber band to the hook and the other end of the rubber band to the anchoring pin. Well, what that does is when that rubber band is dorsal, just like this, it pulls the finger straight. And the reason that is because the moment across here, it just wants to pull that into extension. So this is just the math behind that. Because the rubber band's represented in red here, because it stays dorsal to the axis of rotation, there's always a force that's pushing the finger straight. Now, what happens if the rubber band goes on the other side of the axis pin? Before it was up here, now it's volar. Well, that tends to flex the joint. So this rubber band concept can be used, it mimics the lateral band in the native finger, and it can be used to help to regain motion in a contracture cases, or it helps as a built-in therapy. And this is just a demonstration of what that looks like. So here's the external fixator put in the dynamic mode, and these are just dental rubber bands that you use for braces for your teeth, and we're hooking it on. So the bands are initially placed dorsal to the axis of rotation, and what you can see is if the fingers flex down, those bands will pull the fingers up. And if you leave this long enough, just like I did here, this is what I just did at the beginning of this talk, you can look closely and you can see how that joint goes into hyperextension. So vice versa, if you put the rubber bands volar, it will pull that joint into flexion. So you can see how this can help with finger rehabilitation, or it can also help and used for contracture cases. So the elastomer bands, once again, is a built-in therapy, and it can be used in conjunction for post-traumatic PIP contractures or even Dupuytren's contractures. Now, here in the US, we are the only company that has obtained FDA approval for this device to be used for Dupuytren's contracture. All the other devices, for example, like the Hand Innovations, the Digit Widget, it is not specifically FDA approved for Dupuytren's. Only the DigiFix is. So here's a case I just want to show you of extension contracture. So this is, you can see his CT scan and the fact that, you know, I could not flex his finger under anesthesia any more than that. That was it. And this is because he had an injury and couldn't be treated right away. So here's what we did. I did a contracture release on him by taking down the volar capsule as well as collateral ligaments. And then I applied the DigiFix with the rubber bands. Here's the anchoring pin here. And this is what he looked like at 4 months after surgery. So his extension is not bad. And you can see his flexion here. He can flex that finger into the palm now. So in summary, you know, the DigiFix external fixator was specifically designed for the hand. There's the frame itself, or what we call the brackets. The length is adjustable. It can be shortened or it can be lengthened. It's very versatile, where it can be used in the static and dynamic mode. And additionally, the elastomer bands can be used for contractures or as built-in therapy. So that's the basic presentation, and maybe at this point we can take some comments or questions.
Do you have some tips when you use the two bars, okay, to do the same lengthening of the two bars to avoid angular deformity?
Yes. Okay. Good question. So let me go to a video that I have, and maybe we can, that will answer some questions here. So please give me one moment.
Okay.
There you go. So here's a video, which helps with that. Okay. So the thing to do, the real key here is to get the axis of rotation correctly. So the first thing that I like to do for this is just stabilize the joint where you can put a pin in dorsally and that blocks the joint. So then after you do that, the axis of rotation is approximated by this point. Let me go back here a little bit, right? So this point is determined by when you flex your finger, it's the flexion crease of the finger, and that approximates the axis of rotation around the head of P1. So then this is the whole key to the procedure here. It's to drive that pin so that it's perpendicular to the long axis of the P1. And then after you do that, right? So this is important here to make it perpendicular to here, and it's not rotationally off in the coronal plane. And then what you do is you slide on the bracket, right? And then you use the bracket itself as a guide. So now when you're putting in this K-wire, you make it parallel to this one. So you use this bracket as a drill guide to insert the K-wires. Right? And you try to make it as parallel as possible. If it's off a little bit, it is accommodating enough, but you don't want it to be off too much. Otherwise, you will get that rotational deformity. Does that help answer the question?
Okay. The question is, if you need to do a lengthen
Yes.
of the distraction of the joint.
Yes.
And you are using the two bars, okay?
Right.
Do you have a tip to do the same
okay.
length of the bar
okay.
to do the distraction?
I have your question. So the tip there is to, the way that I lengthen it is to check it under fluoroscopy. And the way that you want to look at it is to make the joint not like this, open up like this, but open up parallel. So you can lengthen one side or the other. If one side is shorter, then I would lengthen this side to bring it out this way. You see what I'm saying? And I check that under fluoroscopy to make the joint surfaces parallel.
Okay, nice. Thank you.
You're welcome. Thank you. Okay, perfect. So for the proximal wire going through the axis pin, they are 1.4 millimeter in diameter. If it's in a big person, somebody who's really big fingered, then you can go up to 1.6 millimeter. It will accommodate. Okay. The only time that you might have trouble is if you cut the end of the wire. Sometimes, depending on your wire cutter, it will leave a little bit of barb on the wire and it doesn't fit through. So fit this through the end of the wire that is not cut. For the distal wires, we recommend 1.1 millimeters. 1.1 millimeter wires, and the 1.1 will fit through any of the 4 holes here. There are 4 holes there, and they all should be 1.1 because when you tighten down the set screw, they all lock all those wires at once. If they are different sizes, they will lock only to the largest wire. So that's why if you keep them all the wires of the same diameter, all the wires will lock on at once.
Can I use it on an MP joint?
You can use it on MP joints, but only for the border digits, for the index and for the small finger. If you want to use it in a dynamic mode, because the fixator needs to go on laterally or radially and ulnarly. So let me see. I think I have a example of that. Let me see here. So here's one for the MCP joint. So you can see how this is for a small finger. She had an injury here and a bony deformity. So you can see how this pin goes through about the axis of rotation at the MCP. Now, you have to realize that the MCP joint is not a straight hinge joint as the PIP is, but you approximate it as much as you can. So same concept here is that this wire goes through and then 2 or 3 or 4 wires distally. So, and you can use the rubber bands there too. The MCP joint is here. This pin is going through the axis of rotation of MCP. And this is her range of motion. And she did not have any ability to flex her MCP joint at all prior to this. So here's another case of a MCP contracture. Same concept. You can see how, right, with the rubber band on, afterwards, the rubber bands pull the MCP down into flexion. And she was unable to get her finger into a palm before. Now, is the motion perfect? It's not, but it was better than what it was before. So you can use it for the MCP joint, but it has to be on the border digit.
Thank you.
Thank you. So let me show you, this is a case of Dupuytren's contracture, right? So he had mainly PIP contracture. You can see the Dupuytren's cords there. And I don't have the surgical video, but what I did was I performed a very limited fasciectomy, right? You can barely see where I did the incision, and this is only 2 months after surgery. And the key for me when I'm doing surgery for Dupuytren's contracture is that, you know, a lot of times it's easier to take out the fascia here in the palm, but as you get out into the finger, it becomes much more difficult because of the neurovascular bundle. So I believe that the DigiFix allows you not to chase after every bit of the fascial cord here in the finger. And because of the constant pull of the rubber bands, you can get close to normal range of motion. Now, like all Dupuytren's contractures, the contracture will come back in the future because we're not changing any of the disease process itself. We're just changing the mechanics of the disease process. There's another video here, if I can find, or another presentation where it's, let me see if it's this one. This is a similar. But I think it's very versatile in contractures. Now, contractures for hand surgeons, they're one of the more difficult things to do, to get to treat, because especially of the small finger, the recurrence is actually very high. So I think that anything that you do to help get a better result is actually a good thing. Okay, so here's what I was saying. This is somebody who had an amputation through here. So the finger became a rigid contracture. There was no way that we could move this, even with therapy and everything else. And because of the amputation, I really didn't want to open up and do a formal contracture release. So basically, all I did was place the dynamic fixator on without opening the joint at all, and use the elastomer band to pull it out into extension. And just over 6 weeks of just applying the rubber bands and some therapy, he came out from 90 degrees to about 40 degrees, and he ended up having a fusion at that position. Right. So here's another case where it's a very bad Dupuytren contracture, where the patient had had fasciectomies and had had the Xiaflex injection. And again, same case, similar case, where I did not want to have to go and open her up on the volar side and do a contracture release. So I basically placed this the DigiFix on percutaneously and used the rubber bands to pull her into extension. So she had the DigiFix on for 4 weeks, and this is her 1 week after removal. And remember, I did not open her up volarly at all. This is prior to the DigiFix. This is 1 week. This is just 1 week after having the DigiFix on, and this is 1 week after removal. So the finger came out straight, or close to straight, right? And that's her active motion. Obviously, we lost some flexion, but with Dupuytren's contracture, you always, you just basically change the range from a more flexed to a more extended position. Again, what I want to stress in this case is that this is a woman who's failed fasciectomy, who's failed Xiaflex, and I didn't want to go back and open her up on the volar side. Now, initially, I did not do her initial surgery or the Xiaflex. She came in to see me to see what else was possible. And the only thing that I could think of offering her was the treatment with the DigiFix. So here we talked about, again, for the MCP joint, this is another Dupuytren's contracture, right? This is Dupuytren's, but it's more MCP. And I did a very limited fasciotomy here. She had a revision carpal tunnel release at the same time. And this is, the fixator was on 3.5 weeks, right? And this is her range of motion 6 days after the DigiFix was removed. So you can see how little surgery is done. And because there's little surgical dissection, we don't have to worry about the soft tissue healing, and she's able to regain her motion much faster. So those are, some of the basic cases that I think are important when thinking about the DigiFix. Now, everybody thinks, when we talk about external fixator for the hand, for the finger, most people think about just the trauma aspect of it. But what I'm hoping to do is also share my experience and get it out there that the external fixator can be used for contractures or more chronic cases and for Dupuytren's contractures. Can I answer any more questions? So George and Andre, what questions do you think, you know, having seen this a couple of times now, what questions you might you anticipate either from your sales rep standpoint or from a surgeon who's never seen this before?
I believe that the right way to build the system for each kind of procedure is one of the main questions that we have. So if you can make a short review of that, should be very great.
Okay, so the technique itself.
Yes.
Okay. Let me bring back that video that I had earlier.
Dr. Virak, I think that we have a question.
Yes.
If is DigiFix recommended for pediatric patients, for children?
So we have used it on pediatric patients. It is just the size. I think that the limitation is just the size. So because the bracket only comes in one size, and oftentimes if the finger of that child is on the smaller side, the bracket might be too big for that.
Okay.
So personally, I have used it in somebody who was 11 years old. I know there are surgeons down in Dallas at the Children's Hospital in Dallas, where they have used this on at least 10 to 12 cases, but I'm not sure what type of cases those were.
Okay. Another question, what kind of fractures do you think that DigiFix performs better than plates?
Oh, you know, for me personally, I don't like the plate proximal phalanx or middle phalanx fractures at all, just because I feel that there's not a lot of soft tissue that is forgiving. So very much so, in my opinion and in my experience, every time I do an open reduction and plating, there's a lot of scar tissues. And as you know, a lot of the plates for the fingers are at least 1.1 millimeter or 1.5 millimeters thick. And even though that's relatively thin, I think in the finger is still pretty thick. So I feel that the extensor mechanism definitely gets adhered to these plates. So in my hands, I try to avoid it. So what I do is, if possible, what I do is I will do the open reduction and maybe just use a screw to stabilize the major fragments, and then if I can, apply the external fixator. Now, every case is very different, but definitely I think the shaft fractures in my hands I try to avoid. Definitely for any joint involvement of the PIP joint, I think external fixator is much better than any open reduction. And my goal when it's a periarticular fracture of the PIP joint is not to necessarily get perfect joint reduction, but is really to get joint reduction that is good enough, but then to start the motion right away.
Okay, and Dr. Virak, only one more question.
Okay.
When do you use the proximal row locked, and when you use the proximal row unlocked?
So you're talking about this hole right here?
Yes, yes.
Right. So that's a good question. So for static, I will go ahead and put a pin in there and then lock it. So that will provide, because remember this, let's go through here again, right? So you can see how this whole bracket is moving around that pin. Well, if you put another K-wire in here, then it cannot move. This part will not move, okay. Right? So that most proximal hole is used in the static mode, right? And it's only used in the static mode. The rest of the time is not used. Now, sometimes if you have somebody, a very large finger, so instead of using this hole for the axis pin, I will go ahead and use this hole. But that's not that common. You have to have somebody who's really big to in order to do that. Okay.
Okay, thank you.
So we'll run through this this video.
Então, como vocês puderam ver, vocês estão podendo também assistir no vídeo, acho que um grande benefício desse fixador é você poder fazer o bloqueio, tanto proximal quanto distal dele, né? O bloqueio distal você consegue fazer em basicamente todos os furos, né? E ele está até marcando. E o proximal você consegue fazer no primeiro furo, né? Então, tem essa opção que eu acho que é bem interessante. Aí o momento da distração, que é a hora que ele aperta o que ele chama aí de diamante com alicate.
I think maybe the last important thing I want to share with you is probably the distraction. And there's just 2 slides here. I think, can everybody still see that slide?
Yes, we can.
Okay. So here, this is distraction just by using the different holes, and where you're not deforming or changing the length through the diamond itself. So we touched upon this before. So for example, if you have this construct on here, right? The distance between here and here, that's fixed. So now if you want to get more distance, you can move it, you move this pin to this hole here, and you can see how much space you can gain here. You can gain about 3 millimeters of distraction by doing that, because between here and here is about 3 millimeters. Okay, so if you need to do a lot of distraction, that's one of the techniques. So vice versa, if you want to do the same thing on the distal end, where if you go from this construct to this construct, just by, instead of using this hole, you go ahead and move one hole distal, as here, you gain a little less than 3 millimeters of distraction. So just by changing which holes you put the K-wires through, you can gain about 3 millimeters distraction. And if you do both, you can technically gain about 5 or 6 millimeters of distraction. Now, in my experience, typically, that's really not required in the majority of cases. So now, when do I use the pliers? It's only when I need to distract just a little bit, about a millimeter or so. That's when I use the pliers to do that. Or after you put on the external fixator and you see that one side of the joint is a little bit more, the joint is uneven and one side is a little bit more closed down. So then you go ahead and lengthen the bracket on that side so that it brings the joint so that it's parallel. Okay, and again, I check that on fluoroscopy. That's how I determine whether I need to distract or not. That's it. So those are the two methods. The diamond is used for fine tuning, just a little bit of distraction, and then I use this method if I think I need a lot of distraction.
Okay, so you have two kind of distraction that is possible to do with the system.
Yeah, you again, there's a versatility in this. You have different ways of doing it, and that's the feature of almost all external fixators, and it's very similar to the DigiFix. It has a lot of versatility, so you can use it, or you can use it in different methods to achieving similar things, similar goals.
Okay, Dr. Virak, and one question, do you use two pillars to shorten and to distraction at the same time? When you use on one side and on another side after?
So do I use two, what was the question again? Can you repeat that? I'm sorry.
Two pillars at the same time?
No, you can do it. You can do one at a time. So you can go do one side, and then you can do the other side. So you don't have to do it all at the same time. Okay. I think that's the question. Yes. So the question is, do you have to squeeze down the both brackets at the same time? No. You can squeeze down one at a time, then check it under X-ray, and then adjust it, and then go to the other side if you would like.
Okay, thank you. Thank you so much.
Thank you. This is just from the pull of the rubber bands. You can see how, I don't know if everybody can see that, where the joint itself is going into hyperextension now, right? Okay. So this is just from the constant pull of the rubber band, and that's how it slowly stretches out the contracture. Okay. And the advantage of doing it this way versus the Digit widget, I don't know if the Digit widget is available in Brazil or not, but the Digit widget does not hold the joint in place because of this axis pin here. This axis pin that's in here, the rubber bands cannot pull the joint out of place. Where in the Digit widget, because there is no access pin that binds everything, I have seen one case where it pulled the joint and dorsally subluxated it. And I think the advantage of this system is that it doesn't allow that to happen.
That is asking about the contraindications.
Okay, so contraindications, just like with all external fixators, if there's poor bone quality, I would not use it in that case. Or if there's an active infection, again, active infection, sometimes there's no good options, and I have used this in the case of chronic osteomyelitis, and it worked out well. Because bottom line is, when you have an active infection and you need to stabilize, what else can you do? You know, there's not much else that you can do. So I think, although that is a stated indication, it's a relative, it's a stated contraindication, it's relative, right? So
Whoa.
you can see this, right?
Yeah,
so
you can see.
Here is a case that, again, I didn't do the initial surgery, but obviously a lot of trauma to it. This is 4 months after, and these pins were still in. Obviously, there's a non-union here, and it became an infected non-union. And this is when I took him to the OR. You can see the entire thing is unstable. The dorsal half of the bone's missing, right? So what do you do for this? The finger's unstable, it's infected. So we just decide to clean it out and apply the X-Fix to fuse the PIP joint, as well as to stabilize the bony defect. I added an additional dorsal K-wire here, or an additional wire, just to help with stability. And my plan was to come back and bone graft this after healing, but I didn't need to, because just with that, you see the PIP fused and the non-union healed. So that's like we talked about before, it's a relative contraindication for an infection, but sometimes there's no other good option. Very good. Thank you for all your time.
Okay.
Okay.
Bye-bye.
Bye-bye.
Bye-bye.